Okay, so welcome everybody. My name is Sohail Sood. I am a UCSF pediatrician and one of the directors of the Global Child Health Lecture Series. Um, it's my absolute pleasure today to welcome back Emilia Connolly and her colleague Isaac Mphande to our lecture series. Emmy is a pediatrician and public health implementer working as chief medical officer at Partners in Health in Neno Malawi. She's also a hospitalist working at Cincinnati Children's Hospital Medical Center. And as part of the inaugural cohort of UCSF's HEAL Fellowship, she served at a medical center in Fort Defiance, Arizona, and at Bwenzi Paza Umoyo in Malawi. Completed her residency at Jefferson Hospital in Delaware and received her MPH from Berkeley and her medical degree from Rowan University, School of Osteopathic Medicine. Isaac, her colleague, is a advanced midwife practitioner working with Partners in Health in Malawi as the primary healthcare nursing manager. He has a master's degree in midwifery, a bachelor of science degree in nursing, and a university certificate in midwifery, all at Kamuzu College of Nursing. He's a fellow of the Global Nurse Executive Fellowship and Africa Maternal Child Health Nurse Leadership Academy, and has a certificate in management and leadership in health from the University of Washington. They're both here today to talk about the creation of Pediatric Development Clinic in rural Neno Malawi, and to talk about universal healthcare in that context. So absolutely my pleasure, and take it away.
Wonderful. Thank you so much for that introduction, Sohail, and so really wonderful to be here with everyone today. I always love doing these lectures and all the questions and discussions that we have. So let us get started. I just had a really wonderful introduction, but I think I'll just add one or two more things, and then I'll let Isaac come in and take us through his sort of motivation and then into the start of the presentation and overview. As Sohail said, I have been working in Malawi, and it's been in several senses. Initially as trainee as a pediatrician, and I actually helped start the nursery in Neno District Hospital, which is then sort of a continuum of this work. And so it's just really exciting to be thinking through the process of since a baby is born, how do we take care of them, and then throughout this process. And this is sort of the motivation of starting this clinic and thinking about this work. So really excited to talk through with everyone today with a lot of like minds in the room, and excited to get started. I'll turn it over to Isaac to give a short introduction and then just overview of what we're going to talk about.
All right, thank you, Amy. I hope all of you can hear me. Yeah, so thank you again, Sohail, for that nice, wonderful introduction of me. Yeah, and I have been in practice for the past, I would say, 7 years before I actually moved now to a more managerial role where I am actually supervising teams in mentorship, coaching, and stuff like that in mostly the rural setting. So I joined PIH 3 years ago. And I started as a mentor, then I was promoted to this role of becoming now a nursing manager, which I've done for about 2 years. So without wasting much of your time, let's go straight into the presentation. So here I hope you'll be controlling it from that side. You can take us to the next slide. Yeah, so thank you so much. So in the area where we are working in Neno, it's predominantly hilly, and most of the facilities that we're serving are very hard to reach. So I wanted to give you that background before I actually dive deep into our today's business. So there are quite a number of reasons why we decided to set up what we call a pediatric development clinic within the setting where we are working. Simply because when you look at the situation globally, you will see that about 350 million children who are less than 5 years in low and middle income countries are at very high risk of developing conditions like malnutrition and many more, simply because of issues like poverty and also scarcity of the necessary medical interventions, nursing interventions that they would benefit from when you look at even the resource constraints that we're facing within this particular setting. So 95%, which translates to about 52.9 million children, they do have problems of delayed developmental and disability conditions. And this particularly is, I would say, enhanced simply because of the way or the areas that we are situated in, where you have structures of racism, for example, to talk about poverty, stigmatization, poor nutrition, and lack of recognition at that level where you would, as health practitioners, intervene quite early so that whatever happens subsequently in their life, possibly maybe we might save them from some other complications that would develop because we intervened late in their life. So this is also quite, I would say, complicated, simply because we are working within a health system that has a lot of issues already in it. We are looking at lack of systems that are established to do away with such kind of conditions, which actually complicates issues to do with policies, which leads, to the cycle of, again, poverty. So we have kids that would benefit from, let's say, the Pediatric Development Clinic, but because when you look at the priorities of a particular government, for example, they would actually prioritize services to do with curative, for example, curative services and emergency services, because they have a very small resource base. And some of these issues, which are to do with kids that are possibly looked at as if they are within the normal category, those ones might be shelved and then possibly considered later when you have like more money or more resources within the healthcare system. So most of the times this doesn't happen. And within the setting that we're working in, it's even worse, because this, if we are to set it up, it's going to be the first of its kind within the rural settings of Malawi as a whole. Next slide. Yeah, so as I was saying, so this is the area where we are working in. So that's a map of Neno district, where we're serving a population of around 145,000 people. And we don't have a tarmac road to access the district. So this is the only district that doesn't have a proper road. And about less than 8% of the population has electricity. So you can see the majority doesn't have. And again, when you look at the setup in terms of income generating activities, you actually see that the majority of the families do rely on subsistence farming, with more than 70% living on less than $1 a day. So us as PIH and as locally known as APIZU, we've been in a district since 2006 with initial focus on HIV care, but now we are moving towards what we call a comprehensive continuum of care, where we would like to provide more comprehensive services to do with curative. We're supporting the Ministry of Health in setting up a district hospital within this hard to reach area, and then also run so many programs across nutrition, maternity, and for example, this Pediatric Development Clinic, which we would want to bring in so that we actually complete, partly the comprehensive care that we would provide within the universal health coverage realm. Yeah, next slide. Yeah, thank you. So before you, as you can actually see, there are two graphs in that slide. So what I wanted you to pick from here is how we have actually fared in terms of the other programs that we've implemented within Neno. So we have we developed a neonatal nursery at one of the district hospital in Neno. So I forgot to mention one thing. So within Neno district where we are situated in Malawi, we do have two hospitals where we provide CMOC. So this is comprehensive emergency and obstetric care. And we are surrounded by about 11, 12 primary healthcare facilities that some of BMOC, so that's basic emergency and obstetric care, and the others do just provide other services apart from maternity services. So we set up a nursery with the help of Dr. Amy when she came to Neno and team. That was back in 2016, where we have been seeing so many children, neonates, I would say, with conditions like sepsis, birth asphyxia, respiratory distress syndromes, predominantly due to prematurity, and some of them do develop hyperbilirubinemia, so that's jaundice. And because of that, we developed some programs to actually respond to that, to the effect that now we have implemented successfully what we call the WHO Safe Childbirth Checklist, which some of you, I think you might have gone through, maybe you know it. And through the implementation of that mentorship program, what we've seen is that even when you go through those graphs, you actually see that we have seen trends, improvements mostly in neonatal deaths and for example, you actually see that from the graph on your left, you actually see that we still have kids, many children being born with their weight less than 2,500 grams. So these fall within the category of what we call low birth weight babies. And we also have many kids also being born preterm. And on the other side, when you look at the actual neonatal deaths, we as a district have been doing, I would say, a little bit well, in now that despite all this, you can actually see that there is a decrease in terms of the actual neonatal deaths. So this probably speaks volumes on the implementation of a mentorship program with an evidence-based or proven tool within a rural setting where you would actually see that you can get some of those gains as pictured in these two graphs. So before I move on to the next slide, I also wanted to give you a picture to say this is not the only intervention that you could provide. You know, it doesn't really end here. And by just looking at the high numbers of preterm births and low birth weight babies, you'll actually see that there's a lot of things that we could do to actually respond to this type of a trend within a primary healthcare setting. So some of the things that we could do to provide comprehensive care is to monitor those kids to see how are they developing. And we also are obliged as service providers to provide them with a home where probably we need to monitor them and make sure that they are growing properly and they become useful citizens within a nation. So next slide, Sohail. All right, yeah. So now I wanted us to look at, sorry, Amy, you ready to take us through this one?
Sure, yeah.
All right.
I'll take us through the next few slides before turning it back to Isaac, but thank you so much, Isaac. And I'm actually controlling Isaac, so just so you know.
All right.
But this is a perfect intro from the last slide. So you can see that mostly due to follow and understand how many premature or low birth weight babies there are, we have seen increases, but most of that we believe to be reporting and better education with nurses and midwives to be marking babies as low birth weight and premature. So the next question becomes, we have more of them that we found and that we're taking care of, and they're surviving through their neonatal period. So how do we set them up to thrive in life? Now, luckily, I know we're talking to a group of pediatricians, so this is not a argument that we have to do fully. But I think, as many of you know, and is very well documented through a lot of the World Health Organization, the WHO's nurturing framework, and other studies that have been done, the first 5 years, and especially the first 3 years of life, really are required as high inputs, for a child's life. So if they have good health, good nutrition, a warm, nurturing environment, they have good social supports, that really sets you up for the rest of your life. I think quite often the regular public can think that, when it's a baby, it's not really walking or talking or really interacting with the world, so anything going on around it is not that big of a deal. Or in terms of nutrition, they're just taking milk and that's all they need. So I think it's really important to sort of reframe that aspect of like, no, these first 3 to 5 years are really the most important time in the child's life. And those gains that you get from doing more of that preventative work, as Isaac had mentioned, there's so much focus on the disease, the actual treatment of disease or the emergency piece. But if we actually take a look at the preventative piece and make sure that the children, especially those who are set up at birth to perhaps not thrive so well, so premature, low birth weight, or other, serious infection, that we give them all the supports need. And this has been proven also to have really great economic returns. The children who have early childhood development plans, who have good nutrition, good social environments, have been shown to make and have economic outputs at least 2 times to sometimes more than 3 times that of their peers, and can really make back the money that you put into some of these programs. So I think that's just setting up the notion that even though this is a preventative program and there is inputs and costs that are associated with it, the outputs that you have really can set up for generations in both health-wise. There's lower disease rates of things like hypertension, diabetes, and also economically. So I think for any of you who've maybe been to some of the Partners in Health presentations during this forum before and with me, we always like to pull in an aspect of talking about universal healthcare coverage and just making sure that we always sort of look at our vision and passion, through this lens. So just to quickly go through the idea of universal healthcare coverage, and the definition is really that all people have access to needed health services. And then it's not just treatment of disease, but also prevention and promotion of disease, and also the rehabilitation and palliation piece. I think when we're thinking about early childhood development, and also making sure that children who perhaps have disabilities or chronic disease have everything they need, we really are focusing on most of what is in the aspect of universal healthcare coverage. And that it also is in sufficient, it's of sufficient quality and quantity to be effective, and that the user is not exposed to financial hardship. So you could have all of these things, in the community or area that you are from, but if it requires you to pay money, then that's not considered universal healthcare coverage. So as we move forward, we'll talk about setting up a pediatric development clinic in this lens of how do we sort of move on our care continuum, both in a sort of focus on an individual, but then also in a programmatic state too. So from there, I will pass it back over to Isaac.
All right, yeah, thank you so much, Amy. So also wanted to give you a picture to say, if we are to set up interventions, just like Amy has said, for example, the Pediatric Development Clinic, how do we set it up within the already existing structures that we have as PIH or APIZO? So just to, maybe some of you might already be aware of how we operate as partners in health. In Neno, we have one of our flagship, I would call it flagship programs that we are running within the community, which is called the Integrated Care Continuum within Neno. So this runs right away from the home or the household all the way to the facility. So it is all to do mostly with how we link our clients, our patients, back and forth within these four, I would say, categories. So I would start with the home, as in the household. So here we have what we call the home-based care support, where we have a cadre of people, foot soldiers, and their name is community health workers. So these are the people that are available within the household level, where they do provide longitudinal follow-ups within that structure, and they would actually link any client that they actually see or screen to say might need medical attention, maybe say, for example, at a health facility. So these would do sometimes just refer that person to a nearby health facility, or they would actually accompany that person all the way to the facility so that they ensure that that person gets the care that they need. And again, within the very same community, we do provide what we call community education and integrated screening services for common conditions. So these are conditions like, for example, TB, and we would also maybe screen for things like pregnancy, so that those women that we find do actually go to access ANC within, I would say, maybe the first trimester, for example, where we as the country are doing very badly in that area. Upon identification, so these clients are sent to the primary healthcare facility, like I already said earlier on, to say at this facility, so this is within their community catchment area, and these facilities do cater for, on average, about 10,000 people, and it's a facility that is within the community, and some of them do provide comprehensive services, including maternity care. So these CHWs, what they will do, they would leave that client to the primary healthcare level, where they would get assisted depending on the conditions that they have. Yeah, and we also do have what we call the integrated primary healthcare clinic, which is the IC3 clinic. So it's integrated chronic care clinic, where it's one of our most, I would say, prolific or efficient model, where we provide HIV NCDs within one setup. So these clients are also referred to such kind of a clinic at an earlier stage, so that they get early help quite early. And within the very same, we also do operate the same clinic within what we call the primary healthcare system. So this is the first facility that someone would get to. So it's a get in, I would say, facility into the healthcare system in Malawi, in the sense that if someone is found to be, maybe have like more complications, they would be sent now to a secondary care facility, which is now this big district hospital that I earlier on talked about, where we also have the only nursery within our district. And within this same setup, that's what we call now the secondary care, where we have comprehensive diagnostic, I would say, services. For example, we could diagnose things like rheumatic heart disease and issues like those. And I would also hospitalize clients if need be. So that's what we actually operating within. So in terms pediatric development within this continuum. Yeah, Amy, you can. Yeah, thank you. So in terms of how this pediatric development clinic would fit in within this system, you'd actually see that it's tapping in from almost all the parameters that I've just taken you through. So thinking through, for example, when you review the continuum, you'd actually see that within Neno, through partners in health support, we do implement, I would say, a comprehensive integrated care cascade, starting from right away from the home to the facility. So meaning to say that even with the pediatric development clinic that we are thinking of implementing, introducing in Neno, we would actually still rely on the same system in that, for example, if we have a kid that would require support from the pediatric development clinic, this kid could be identified within their household and then through the already existing structures be referred and linked directly to the pediatric development clinic. Likewise, if the pediatric development clinic would want to actually go and trace someone or a kid and her parent within their household, we would actually follow through the very same already existing structure that we could actually pick that kid wherever they are and then link them to proper services. So there are so many things that we also need to think about as we are implementing this, simply because there could be some kids that we envisage possibly that they would be missing their appointments. So those kids, possibly we have to find a mechanism of trying to trace them back and then bringing them closer to care so that we intervene before they actually develop complications. So this is how we are thinking about in terms of setting this PDC within the already existing integrated care continuum that we have in Neno. Yeah, next slide, Amy. Yeah, so also thinking through the WHO nurturing framework. So as in the other big question would become now, where do you actually start from to think about, setting up such kind of a clinic? So when you look at the WHO nurturing care framework, there are actually 5 strategic actions that we need to think about. So the first thing is, thinking about how do you lead and invest. Then there is also a big component where you need to focus on families and their communities, and then think through how best you would strengthen the services that you're providing and monitor progress, and then the use of data and how do you innovate afterwards. So this also requires what we call 5 components, where we look at, we emphasize on issues of good health, adequate nutrition, responsive caregivers that are better equipped to respond to whatever I would say conditions that would come out. Then you look at security and safety and other opportunities that are there for early learning within that very same setting. So when you look, for example, at specifically for children with developmental delays or disabilities, they actually need additional strategies. So strategies that you would actually think through, for example, strengthening formal services and support, like I already earlier on explained about the integrated continuum of care, and then especially within the community and within the primary healthcare realm or set up the system that you have. Then you also need to think through raising awareness within the community so that you reduce stigma and improve access to care. So because of the conditions or the stigma that these women or the parents to these kids go through within their households that they are living in, they are sometimes given names, and sometimes they are left alone to take care of those kids with developmental delays and some disabilities, simply because maybe the father doesn't want this woman to keep that woman, that baby, for example. So it is now reduced to just the woman taking care of that child alone, and doesn't have all that support from the community simply because of the stigma that exists. We still have cases where the father has actually abandoned his or his wife within the hospital simply because they have given birth to a kid that has, for example, disabilities. So those things possibly are some of the things that we really need to think through. And that also links straight to, thinking about a package that you would provide to support the family and the parents. So that's thinking about social support. And also looking at how best to empower these caregivers to provide the necessary care to these kids so that they don't develop other complications such as anemia, malnutrition, simply because, for example, they were failing to just feed such kind of a kid. So connected to the same, in the picture there, you would actually see a woman that is holding a baby. So there's also a story behind that. So we call that baby, we called the other baby Prince, and was born with a weight of less than 1,000 grams. So was a very preterm baby. And through the same support and the nursery that Amy and team helped put up, we managed to keep this baby on KMC for quite some time up until this baby actually responded. So we were thinking through giving such babies a home like Prince, where after discharge, for example, from KMC, they would go through still a certain home, which is now in this case, the Pediatric Development Clinic, where we would follow them through and see how best they are growing and prevent other common complications that they would have so that they actually realize and become good, full, I would say, contributing citizens to the development of the country. Next slide, Amy. Yeah, so this pretty much speaks through our vision of the pediatric development. So this is exactly what Amy already talked about. So within this, we are possibly planning, and when we look at the bigger picture of our PDC, it's that we would provide more or less like a home to the most vulnerable kids that we have within our catchment area. And the target is we're targeting children less than 5 years old for the reasons that Amy earlier on talked about. Those kids that do have conditions like developmental delay, disabilities, and we would also want to monitor at-risk children through screening services. To provide what we call clinical care, developmental and parental education, peer groups, physiotherapy, feeding, counseling, social and guardian mental health services. So summed up all this, we hope that we will impact greatly on the survival of these at-risk kids who are falling within the age group of under 5s. Yeah, next slide, Amy. Yeah, so there are other big questions that you would actually ask to be, so who are the people that we think we would be saving? Yeah, so as you can actually see from the slide, infants from the special care nursery are at a very high risk of developmental delay. As you actually saw from the graphs that I beamed earlier on, you'd actually see that we still have many kids that are being admitted within our nursery because all those kids, premature, low birth weight, those ones, we admit them before we actually discharge, because there are so many interventions that we have to do on them so that we prevent complications later on. So these are the babies that would fall, like I already said, within prematurity, low birth weight, sepsis, hyperbilirubinemia, and respiratory distress syndromes, as well as birth asphyxia. So so the children that we also expect to actually see within this clinic, or the children that we actually envisage to save also, are kids that do have conditions like genetic conditions like chromosomal or neuromuscular disorders, those babies with birth asphyxia or cerebral palsy, and some of them that have unknown causes of developmental delays, and those that have feeding difficulties, and some children with NCD, HIV, and developmental delays, thinking through kids that we have been seeing with epilepsy, sickle cell, and childhood stroke. So, for example, kids with epilepsy, we have been seeing them, but through what we call the integrated chronic care clinic, but we wanted to now enroll these kids, take them out of there and put them together with the other kids that we fall within the categories that I've just explained, so that we follow them through together within one specific home for the kids. So those are, just in summary, the population of children that we expect to save. Yeah, next slide. So as we think through this whole pediatric development clinic, you'd actually see that we need pretty much so many allies and friends that would help us possibly set this up and for it to become a success. So we went to our colleagues that have experience in implementing a similar project within a similar setting as ours, so that we could learn from them how they actually did this. So these are our colleagues from Rwanda. They're also partners in health. So from that side, they managed to give us a lot of lessons and share some materials to us, which we would actually start with. And also partnering with Liverpool Wellcome Trust, Harvard School of Medicine, Nest 360, which is a team which is leading in neonatal care within Malawi, and the local pediatric team within our central hospitals, the rehabilitation unit, physiotherapy, as well as our nutritional unit, and policy experts and donors from the national as well as a local setting. And we have also, to that effect, created what we call a technical working group within the Neno district, where we have gotten all the key departments within the district hospital, so that we sit down as a multi-level team and think through how best we would implement this within the setting that we are. Next slide. Yeah, so the other thing that we are looking at is on the initial PTC package. So as we sat down, we actually had, you would agree with me that there could be so many things that we actually were thinking through in terms of how best do we structure and make a specific unique package that would actually benefit the population that we would want to save. So we just summarized the package into the boxes that you can see from your left. So we're thinking through the referral and linkage to care, where we are thinking of, for example, a baby that is within the nursery. How do we best link them to CMAM, for example? So that's community malnutrition, and within kids that we are getting from the nutrition rehabilitation unit, and even from the NCD clinic, and even from the wards. How best do we make sure that these kids requiring pediatric development care support do get to the pediatric development clinic? And when they get there, even before they get there, what type of screening do we want to actually do? Yeah, so thinking of things like vital signs, then thinking of screening them for if they have malnutrition or not, if they have conditions like TB, which is very common in Malawi, HIV, and if they have developmental delays. So on developmental delay screening, you would actually see that there are so many tools that we have, but we have what we call the Malawi Development Assessment tool, which we want to use within our clinic, because it's one of the tools that has been proven effective for a setting like ours in Malawi. So that's what we want to actually use. And we also would want to provide general counseling and parental education. So we'll be engaging in their nurses and also a social support worker that will help us with that. And we also hope that we'll be conducting clinical reviews and specific counselings. So we have our nurses within there. And if we have a condition that possibly requires a clinician's hand, we are implementing this within the integrated care clinic, where we already have many doctors that are experienced in looking at kids with such kind of conditions. So we would actually refer them to them within the very same one roof. And we're also engaging our physiotherapy counterparts so that they can provide physical support. You know, how do we support a baby with developmental milestones delay to actually feed properly? How do we position a kid with cerebral palsy so that they get fed quite well and they don't develop conditions like anemia and malnutrition? And also thinking through the social support and psychosocial counseling so that we help these mothers to take care, these mothers and parents to take good care of their kids. So we could think of things like group counseling sessions where parents with experience would actually share with their colleagues within the same group on how best they actually take care of their kids. So like expert parents, and then also thinking through interventions like those ones where we bring in people who have gone through similar conditions and how they have actually managed to go through that and raise their kids through the same. And also thinking through the early childhood development, where we are actually running what I've just talked about, the expert parents actually taking their colleagues through some modules and also some group counseling sessions so that their colleagues would also learn some of the things that others do, and then they can share experiences so that we help them psychologically as well as physically and mentally. Yeah, next slide, Amy. Yeah, so in thinking about inputs, the circle that you can see to your right, this is what as PIH, when we are developing programs, we think through. So it is abbreviated as 5S. And this is our philosophy. When we are developing any program within PIH, this is what we think through. So I will start with the circle. So I'll start from where it is written staff, STAFF. So when you're setting up a project within Partners in Health, we think of where do we get the necessary human resource to do this. So with our Pediatric Development Clinic, we are thinking of having 2 nurses. So one nurse leads as a Pediatric Development Nurse Mentor, and then the other one supports as a Pediatric Development Nurse to be doing all those assessments and administering all those comprehensive assessments, as in the Malawi Development Assessment 2, the malnutrition assessments, and what have you. So apart from this, we're also thinking of having people like a clerk and also the social worker to support with other activities within the very same screening, the very same clinic, where they could do things like, for example, vital signs and also some counseling and emotional support. And now moving to the second staff, as in the STUFF. So this is where we are thinking of developing some interventions or ensuring that the tools and the resources that we need for care are actually available. So here there's actually a blend where we're looking at the actual things that we need to use, equipment that we need to use, for example, the MUAC tapes, weighing scales, and also striking a balance with the other equipment that are a little bit, I would say, not very complicated or but they would help you with, for example, administering play sessions to the babies or the kids. So this could be like playing toys, and then also looking at some physiotherapy equipment that we would need to actually run this pediatric development clinic, so that, for example, if you want to position a baby or a kid, you'd actually use. So things like pillows and maybe some special chairs, things like those, so that we can actually support our babies better. And in terms of space, so now you look through to say, where do we actually run this type of a clinic? So for us, as I already mentioned earlier on, we are implementing this within the space of the integrated chronic care clinic, which is already built, and we have a room in there where we already have some systems already in place. So we'll just put ourselves in there, strategically position ourselves, and then benefit from some of the things that are coming within the very same space that we have already talked about. So in terms of systems, so here in terms of systems is where now we are hoping to, we have designed so many tools to help us now develop what we call a database, first of its kind in Malawi, within I would say district setup, where you don't have we don't have data as I speak to say we can actually follow to say how many kids do we have with developmental delays, for example. So we want to set up M&D system, set up many tools for screening and monitoring evaluation tools, put them into EMR, put some in tablets, and then monitor through time and see what we'll get in there, and also try to put up a database where we would be now getting necessary data to do with kids with the developmental delays and within the pediatric development clinic. And on the social support, this is where now the social worker comes in. And we're also thinking through the already existing program within Partners in Health, where we call program on socioeconomic support, where we provide some packages to the vulnerable communities, vulnerable parents, vulnerable kids. So we'll think through a package that we could provide to them so that we contribute, and then they don't develop some common conditions like malnutrition, for example. Yeah, so that's a quick run through that. And what are the, yeah, you can go to the next slide, Amy. Yeah, thank you. So what are the expected outputs after we implement this pediatric development clinic? So epidemiologically, as I already spoke, in Malawi, so many kids that we see, they are at risk of developing developmental delays, or having developmental delays, or are already falling within a category where they actually cannot hit their milestones on time. And because of that, we expect that we will actually set up a more or less like a home for such kind of kids, so we can monitor them through, and then impact on their life in that they will have less admissions, they will hit their milestones on time, and then they can be helped with any other risks that they can encounter in life, so that we can save their life. And we're also thinking of creating a model clinic specifically at a district level, which, like I already said, has never been implemented before in Malawi. And we also hope that we can better serve our population in terms of trying to focus on what I would call a neglected area of children who are under 5 with the developmental conditions, so that we could provide longitudinal care and then interaction on the services and provide the services that they actually require. So again, this is also, I wanted to complete the story that I already started telling you about Prince. So this is now Prince when she came back to our facility after discharge. You'd actually see that when you provide comprehensive care and also follow through the babies who are born with low birth weight, you would actually greatly impact on their life. So this is one of the baby that we decided to follow up, because in Malawi, they rarely do survive when they are born with such low birth weight. But you can actually attest to that when you look at Prince and her mother, they are holding her after the admission. So thank you so much. I would now hand over to Dr. Amy to complete the presentation. Thank you.
Great. Thank you, Isaac. That picture always makes me so happy. We have a few more slides around how we believe that this can help advocate and inform policy to achieve UHC. I'm going to just actually scoot through them because I want to give time for questions. I think the point that I want to make here is that in Malawi at the moment, we're not yet talking about sort of the preventative piece and how do we put it into care so that all patients can have equal access. And so one of the ways that we're planning on doing that is, one, creating this as a model that we can bring to other districts, advocating at a central level for it to be part of a central healthcare package, and really trying to expand your concept of what universal healthcare coverage is. And we know that this needs to be decentralized out to a community level. Having a clinic at the district hospital will be helpful. We are going to be providing transport money, but we really need to get this out into communities for screening and treatment into communities. And just placing that patient at the center of the continuum and asking, what can we do every day to make sure that they're well taken care of in every possible way, not just treatment, but prevention, and to set them up in life to succeed, is the way that we want to go. So thank you so much. I want to make sure that there's time for questions. I'll go to the last slide. Just a few references, and then here. So you have our contacts too if you want to get in touch with us afterwards. But I'll open it up now to both of us. Thank you so much.
Thank you so much, Emmy and Isaac. As Emmy was saying, the floor is open for questions. People can feel free to either type their questions in the chat or preferably just take yourself off mute and ask the question directly. Maybe I'll kick it off to start. Your presentation was so great, and it's so great to see such a comprehensive program that you've developed over there. I'm curious, Isaac, if you can discuss a little bit more about the one of the S's about social support. It struck me as you were mentioning the issues around stigma, which are, of course, not at all unique to Malawi, but prevalent throughout the whole world. How you support a mother who maybe has to be separated from her family, and thus income is an issue, plus having to take care of a child with disabilities. What some of those supports might look like.
Yeah, all right. Yeah, thank you, Sohil. Well, quite a tough question, of course, because it requires a lot of team support to actually handle it comprehensively. So in terms of how we are preparing ourselves as in the Pediatric Development Clinic, we want to have two components. So I would start with physical support, for example. So if this woman happens to come from a household where she is failing to provide like some basic needs, for example, within the very same PDC, we should have a small package which can actually supplement on like the food, for example, for this woman. So I don't want to go into the actual details as to say what do we actually provide as in the individual things that you can provide, but you could provide things that are I would call like the basic that we consider basics within our setup in Malawi. So if you can provide her with a bag of maize, for example, that would take herself and the baby for, let's say, maybe 1 or 2, 3 months down the line. providing them with the food within their household. And you could also think through things like providing them with cooking oil and maybe supplement on the other food like beans, for example. But that doesn't really necessarily mean that it's the only things that this woman would need. But what you're doing at the end of the day with the resources that you have is to actually just provide some supplements to this woman so that she can take care of her baby. But now coming to the psychological support and so the social, I would say the psychological support, that's now where the tricky part now comes in, simply because now you need to look at the problem from different angles. So you could start from, you know, for example, she would need emotional support. So emotional support, that's where we were thinking of bringing in someone who has a background from the social welfare issues, for example, where they could sit down with this mother and then take her through, you know, counseling, where she should understand that, yeah, this is a problem, but this is not the end of life. She should also need probably be helped to cope as she takes care of this baby. So the other stress from these parents is because maybe this is their first baby that they're taking care of with such kind of a condition. And the society, in the way that it is structured, is that nobody would want to come and then support this woman emotionally to take care of this baby. So the baby wouldn't have, the mother wouldn't have, you know, like colleagues to talk to and confide in, as in how best she could take care of this baby so that the baby survives. Yeah, and we have been seeing this quite a lot. So, you know, like towards the end, where now the baby has already developed like malnutrition because the mother doesn't know how to support this baby to feed because of conditions like cleft lip, cleft palate, for example. So the baby ends up just choking and not getting the necessary milk into, you know, like her stomach, his stomach, so that they can actually use it for, you know, like growth and stuff like that. So what we want to do now within the very same PDC is that we should sit down with this mother, with these nurses and the social worker, to actually more or less like train and coach this woman within this setup, so that when she is going home, she actually knows how to hold this baby and how to feed this baby so that the baby possibly does respond, you know. So by just responding, that is already a relief to this mother, because she's already, you know, seeing the impact of her efforts with to his, I mean, to her baby. So that's another aspect that we also need to isolate and then look into quite clear. And then the other thing is that we are also looking into partnering quite a lot with the our mental health team, so that they also would support these women with, you know, like comprehensive, I'll say emotional support if need be, because again, this mental health team sits within the integrated care clinic where we are establishing this PDC as well. So it's like that, in that we are looking at the problem not necessarily from one angle, but we are looking at it from a 360 perspective, and then thinking through the package that we have, as in the resources that we have been given. But if we were given so many, like a lot of money, I know Amy would also smile to that, because that would enable us to do quite more, you know. So that's what we are actually prepared to do with the resources that we have at the moment. Thank you.
Great, thank you. It is just after 9 o'clock on the West Coast, so I know some folks may need to drop off. There's a evaluations in the chat if you could fill it out. If you have a few more minutes, Emmy and Isaac, there's a question in the chat that I think, Isaac, you were just covering a little bit, even in that answer, about the roles of training parents. I don't know if you or Emmy want to expand a little bit more on what that actually looks like.
Sure, I can jump in, give Isaac a small break. But in a lot of our programs in Malawi, we have what we call expert patients, or in this case, expert parents. And they're usually patients who have been in the program for a long time and just have a lot of personal experience about how they came to the program, how it's been going for them. And I think that they're really valuable resource for people just to really hear it firsthand. It's very credible and really validating, I think, for a lot of families. So in this sense, we got this idea from the team in Rwanda who's implemented the PDZ clinic. And in addition to sort of just being there and working on some psychosocial support and peer mentoring with parents in the clinic, they've also expanded their role to provide early childhood development sort of practice. They would be paired with what we'd call an expert, so physiotherapy or a clinician, or sort of the social supports, or someone that's providing that piece of the early childhood development, but would be really helpful, and we would train them through that. And that would be our own training and sort of capacity building for them to train them in the early childhood development. So they would be sort of an assistant in that, and then also help. There's a lot of hands-on positioning and parts that Isaac was speaking about that they could help sort of as assistants, with all of the groups and the parents, and really just sort of be the leader of those parents that are in the early childhood development, and also just sort of provide them with like what happens along the way, and this is where my child would. So for example, like Prince's mother has so much experience and would come into the nursery and talk to the mothers, and it just provided a lot of reassurance, and also just someone to ask questions that you're perhaps afraid to ask, a professional in that sense. So hopefully that answers your question, but are really super cadre to have.
Excellent. Well, thank you. Really appreciate your time, your energy, and most importantly, the work that you're doing. As Zach put, Zikomo. Thanks also for putting your email addresses in the presentation itself. I imagine it's okay if folks reach out to you for any other questions they might have. Excellent.
Please do.
Yeah, sure.
Great. Any final words? Thank you again.
No, thank you so much. And too bad we didn't have a little bit more time to chat.
Yeah, thank you, team. You've actually been a wonderful audience. And if you need any clarification, you can actually reach us through the contacts we've provided. Thank you so much.
All right, great work. Have a great day, everybody. Take care.
Thank you. Bye.